Hi class, welcome to Pharmacology Unit 4, where we dive into cardiovascular medications. We start off with Chapter 42, which discusses cardiac glycosides, anti-anginals, and antidysrhythmics. And the big condition we want to discuss with this chapter is heart failure. Heart failure is basically impaired pumping ability. It can affect preload or afterload. Um, Preload is the amount of blood that's in the ventricles at the end of diastole, so at the end of filling. And then afterload is the pressure that the ventricles have to push against to pump the blood out to the aorta. We can also have right-sided versus left-sided. The right side of the heart gets blood from the periphery, so that's where it's going to back up to. The left side of the heart gets the blood that is coming back from the lungs for oxygenation, and that's why blood is going to back up to the lungs if you have impaired pumping. There are stages of heart failure. This is just an example of the stages. You don't need to know these stages. What's most important is to know that early stages have less symptoms and progress to symptoms like fatigue, shortness of breath or dyspnea, edema, decrease in physical activity, ability, and tolerance, and it progresses to having these symptoms at rest. Treating heart failure, this is just a snapshot of all the different ways that we can treat heart failure medically, meaning medication management. So we're going to use medications like digitalis, digoxin. We're going to use ACE inhibitors. We can use dobutamine if the patient is in the hospital. We can use beta blockers, supplemental oxygen, nitrates. We can also use calcium channel blockers, angiotensin receptor blockers, or put these patients on a sodium restriction. Usually it's 2 grams per day. Or we can even use a diuretic like hydralazine. Of course, the big thing is lifestyle changes. So restricting that dietary sodium, not taking in excess fluid, weight reduction, and regular exercise. So really heart failure is a complex condition, and there's many different ways that we can tackle getting those symptoms under control. To expand on those non-pharmacological treatments, they're provided here on this slide. And then the important laboratory test for you to know is BNP. It is an enzyme that's, or peptide really, that is released when there is damage to the heart muscle, impaired pumping. We want it to be less than 100. If it's greater than 100, we say it is positive for heart failure. And usually the higher the number, the worse the heart failure is. This slide is an example of education that St. Luke's Hospital gives to their patients with heart failure so that they know when they need to notify their healthcare provider that they're having worsening symptoms. So this is education that we would provide to our patient as nurses. So generally speaking, if they have a weight gain of 3 pounds in one day or 5 pounds in 1 week, if they feel like they're having more shortness of breath, they've noticed increased swelling in their feet, ankles, stomach, or legs, if they have a greater feeling of fatigue, a dry hacking cough, if they have dyspnea or find it hard to breathe when they're laying down, or in severe cases, heart failure, or chest pain. These are all symptoms of heart failure that the provider would want to be notified about. So on that chart that we had on the previous slide, it talked about cardiac glycosides, digitalis particularly, and the common preparation is digoxin. Digoxin helps to increase the heart's contraction ability, which makes it unique and especially helpful for heart failure patients. It does have some bad sides. It has a lot of interactions. The big ones to know are diuretics, glucocorticoids, and acids. We want to avoid herbals, and it gets very bad if patient has low potassium levels. Okay, this slide here shows you all the things that are important to know about a patient who's taking digoxin. Um, so usually we have to monitor their lab values and see what their digoxin level is. So this is one of those drugs that has a narrow therapeutic index or a narrow safe range. We want to monitor for signs and symptoms of toxicity. So that would be extremely low potassium levels could trigger toxicity. Um, if their digoxin level is too high, that could be toxic levels. If your patient has bradycardia, a heart rate less than 60, we're generally going to hold these doses. A common indicator of toxicity is vision changes, halos, and kind of lights in your vision. Digoxin has an antidote. It is digibind. That's a good thing to know. If we give this with an ACE inhibitor, or a diuretic, we want to make sure we're monitoring that potassium level. To carry on, this slide spells out what are the signs and symptoms of digoxin toxicity. What do we need to watch for? So GI distress, bradycardia, headaches, blurred vision, those are the big ones. The antidote, like I said, is digibind. And the treatment that we use if they need treatment because they have too much is we can use phenytoin or lidocaine. And that helps to treat digoxin toxicity. Now, on that first slide where I showed you all the different stuff, all the different medications we can use, we're going to continue on. There are other agents besides digoxin that we can use to treat heart failure. They include vasodilators like ACE inhibitors or ARBs. Both ACE inhibitors and ARBs, they block different parts of the renin-angiotensin-aldosterone system. Diuretics, for example, a loop diuretic like furosemide or spiralaldactone, which is another category of diuretic, and that one with Lasix we worry about low potassium levels because it wastes potassium, and with spiralaldactone we worry about high potassium levels because it's a potassium sparing, so it keeps more potassium. And we're going to talk about diuretics more in depth in an upcoming chapter in this recorded seminar. And then we're also going to use beta blockers. Beta blockers block the central nervous system or the sympathetic nervous system, and that kind of slows the heart rate down. And we're going to talk about beta blockers more too. So vasodilators, I told you they're ACE inhibitors and angiotensin receptor 2 blockers. So what do? They vasodilatate. And the way that they do that is by blocking the renin-angiotensin-aldosterone system. So specifically, they block the conversion of angiotensin 1 to angiotensin 2. And if you need a reminder, I'm going to just walk you through the renin-angiotensin-aldosterone system for review. You should remember this from pathology classes. So what kicks it off is our kidneys release renin to help maintain our blood pressure. Renin acts on angiotensin to form angiotensin 1. Angiotensin 1 is then converted into angiotensin 2. And so this is the part where ACE inhibitors inhibit. Angiotensin 2 is a potent vasoconstrictor, and that increases peripheral resistance and promotes the excretion of aldosterone. And then aldosterone promotes retention of sodium in water, thus increasing the blood volume and the workload of the heart. So vasodilators work to interrupt that renin-angiotensin-aldosterone system, and they also improve renal perfusion and circulation. They do have some side effects that nurses need to watch out for, and that is a dry, nagging cough with ACE inhibitors, and both of them can trigger orthostatic hypotension. ACE inhibitors, they end in PRIL. For example, lisinopril. That's an ACE inhibitor, and we know it because it ends in PRIL. Then we've got the angiotensin 2 receptor blockers. Those are usually reserved for people that can't tolerate an ACE inhibitor, most commonly due to a dry, nagging cough that won't go away. Then we switch over to talk about diuretics. Diuretics are our first line treatment for reducing blood volume, especially if your patient has marked edema and low urine output. You should always expect a diuretic to be prescribed. One type of diuretic is spiralidactone. This one is potassium sparing, so we watch very closely for elevated potassium levels when a patient is taking this medication. Spiralidactone, what does it do? It blocks aldosterone in the body, helps get rid of sodium in water, and it saves potassium. What should we watch for? Electrolyte imbalances, headache, diarrhea, high potassium. And if you have too much or too little potassium, what you're going to see is muscle weakness, including heart problems such as cardiac arrhythmias. There are different types of diuretics, which, as I mentioned before, there's a whole nother chapter just on diuretics we're going to talk about. But the different types of diuretics are listed on the right side of this slide. From there, we go to beta blockers. Beta blockers end in OLOL. Some example would be metoprolol. We are going to talk about beta blockers more in depth in the hypertension chapter. What do beta blockers do? Beta blockers lower the heart rate, decrease the force of contraction, and we have beta cells in two different places. We have beta cells in the heart and beta cells in the lungs. And if it's a beta blocker, it can be selective to just the heart, and we call those cardioselective. Or it can affect both the heart and the lungs. We call those non-cardioselective beta blockers. So beta 1 is the heart, beta 2 is the lungs. So if it is cardioselective, it's only going to affect the heart. If it is non-cardioselective, you can also have it affect the lungs. Therefore, we do not want patients that have asthma or COPD being on a non-cardioselective beta blocker. And I'm going to talk about this again in the hypertension chapter. We've talked about heart failure and all the different medications that we can use to help control the symptoms related to heart failure. We're now going to switch over to angina. There are several types of angina. There's classic or stable angina, and that occurs at predictable stressors. So a patient they go out and they mow the lawn if they're out there too long or it's too hot, they may get chest pain. They've been diagnosed with angina. They have been prescribed nitroglycerin to take. And then if they stop mowing the lawn and rest, take their nitro, the chest pain goes away. That's stable angina. Then there's unstable, and that's when it starts behaving unpredictably. So it doesn't go away with rest, it doesn't go away with nitro, it happens more frequently in a variety of different settings. And then there's a variant, sometimes called prismetal vasospastic. That can happen at rest, but it is a little bit more predictable, and it has to do with spasming of the blood vessels. So where the first two are more related to atherosclerosis plaque, the other one is more related to spasms. So there are different types of medications that we can use to treat angina or chest pain. There are nitrates, beta blockers, and calcium channel blockers. What each of them does is listed on this slide, so please read that. The first one I want to talk about are nitrates. Nitrates are a first line drug for acute angina, and we need to always make sure that patients take their first dose of sublingual nitroglycerin in a sitting or lying position because it will drop their blood pressure. If the patient takes it as a patch or a transdermal, that is a more of a slow released form of nitro. It works for chronic chest pain. And some important teaching for that is that they do need to rotate their sites, remove the previous patch before applying a new patch. So the common side effects with nitrates are headache, low blood pressure, and then the dizziness, weakness, and faintness that comes along with low blood pressure. And so that has to do with, is it a quick release or a slow release? Quick release, think your sublingual tablets. Slow release, it's going to be a patch or an ointment. We can also use beta blockers. Remember, those end in OLOL. These have some important nursing considerations as well. They decrease heart rate and blood pressure, so we should assess heart rate and blood pressure before giving a beta blocker. We do not want to stop these abruptly. They can cause rebound chest pain or hypertension, and they can be very effective for managing chronic chest pain. They can also be very useful after a heart attack. Next up is calcium channel blockers. Most of them end in PINE. So amlodipine is an example. What they do is they kind of help relax those arteries, decrease the oxygen demand, and therefore decrease the workload of the heart. And the beta blockers help decrease the workload of the heart as well as the conduction. From there, we need to talk about antidysrhythmic medications. So a dysrhythmia is an abnormal heart rhythm, and there are several different medication classes available to help control those heart rhythms depending on what sort of abnormality there is. Sodium channel blocker, those slow conduction, prolong repolarization. So it takes longer for the heart to be prepared to beat again. An example of a sodium channel blocker is lidocaine, and that is usually given IV and for rapid atrial fibrillation. Then we have class 2, which are beta blockers, and we've talked about those for heart failure. We've talked about those for chest pain. They can also be used for antidysrhythmia because remember, they decrease how often the heart beats. And usually those, if used for an antidysrhythmic, it's for some sort of non-specific supraventricular tachycardia. We've got class 3, and common class 3 antidysrhythmic is amiodarone. It can be used for tachycardia, both atrial or ventricular. Class 4 is our calcium channel blockers, and we've talked about those several times. A common one of those is ditalazam, and we want to be cautious when using ditalazam with a beta blocker. And the use that we typically treat, the conditions are SVT, supraventricular tachycardia, and rapid atrial fibrillation. Okay, so a lot of conditions, a lot of drugs, and they're going to be repeated. So this next chapter, chapter 43, this covers diuretics. So we touched on diuretics for heart failure. Now we're going to go into greater detail. So there are different types of diuretics. The general purposes for diuretics is to decrease blood pressure and decrease edema. There are several types of diuretics. There are thiazides and thiazide-like diuretics. There are loop diuretics, potassium-sparing diuretics, and osmotic diuretics. So thiazides, they have side effects like low potassium. Loop diuretics are more potent than thiazide diuretics, so they have a higher risk of the side effect of low potassium. And then potassium sparing has the opposite. They have the side effect of having too high of potassium. So what you should take away with diuretics is we watch the potassium level very closely. And then just to touch on osmotics, these are usually used for acutely ill patients, most commonly those with increased intracranial pressure. So these aren't used to help control heart failure or blood pressure. So we're not going to talk about osmotics in great detail. This slide shows you some common diuretics, where they work, and what do we need to watch for. So anytime a patient is on a diuretic, we need to watch blood pressure, sodium and potassium levels. We need to monitor for weight change, do intake and output, assess for dehydration, and especially with Lasix, it can have a side effect of high blood sugar. So if a patient has diabetes and is on a diuretic, we want to watch closely for elevated blood glucose levels. So just some other words of wisdom to remember about diuretics. Be cautious in giving a diuretic to patients that have fluid and electrolyte imbalances, patients that have gout, patients who take digitalis like digoxin, because remember we said that low potassium increases the risk of digitalis toxicity, patients that are taking other antihypertensive medications. And what are our common side effects? Dehydration, low sodium, low potassium, tiredness, weakness, dizziness, weak pulse, orthostatic hypotension. So when these patients change position, their blood pressure doesn't accommodate that change and it goes low, and their pulse will go high. That's orthostatic hypotension. We also need to assess for ringing in the ears, which is what tinnitus is, high blood glucose, high uric acid levels. So again, that links to people that have gout, and then hearing loss, which is unique to Lasix. So diuretics have a lot of nursing considerations that you want to spend some time going over. To talk a little bit more about the individual classes of diuretics, let's first talk about thiazides. An example is hydrochlorothiazide. That's one that you'll see prescribed very commonly. What are we going to watch out for? Low potassium. That is the big one. Side effects, we're looking for electrolyte imbalances, dizziness, headache, nausea, vomiting, and we do not give this to people that have renal failure. Next, we go to loop diuretics. Loop diuretics, a very commonly prescribed one is Lasix. What are we watching for loop diuretics? Low potassium, low sodium, and high blood glucose in diabetic patients, high uric acid levels in patients that have gout. We will give this for people that are having decreased urine output because it produces a lot of urine. From there, we move forward to the potassium sparing. So potassium sparing means it wants to keep all the potassium. So we watch these patients for hyperkalemia or high potassium. Okay? And we're going to have increase in FACS if given with an ACE inhibitor. And it also shows you what are we watching for. We're watching for headache, diarrhea, fatigue, and any changes in heart rhythm. And then osmotics, just to touch base on them, they can be used for acutely ill patients, critically ill patients, to help prevent kidney failure, to decrease intracranial pressure. They have some serious side effects. And mannitol is an example of an osmotic diuretic. And one thing that's unique about mannitol is it does require a filter needle because of how mannitol is manufactured. Crystallization is possible, and using a filter needle will filter out those little crystals. And that brings us to the end of the diuretics. So I've tried to keep it clean and just bullet point what each diuretic does and what are the bullet point things that you need to watch out for depending on which diuretic class has been prescribed. From there, we're going to switch over to antihypertensives. And so let's first talk about hypertension. So hypertension, or our blood pressure, is controlled through a variety of different systems. The kidneys help maintain blood pressure through the renin-angiotensin-aldosterone system. There are baroreceptors in our large blood vessels, the aorta and carotids, that help sense where we're at in terms of pressure. Then there's vasomotor center, so our brain tells us how we're doing with blood pressure. And then we have hormones like antidiuretic hormone, atrial natriuretic peptide, and brain natriuretic peptide. All of these help to keep our blood pressure in balance. There are some physiological risk factors to high blood pressure. Excessive intake of saturated fat and simple carbohydrates, increased intake of alcohol. We know that there are some cultural differences in how some patient populations respond to antihypertensive medications, and we touched base on this in the cultural unit. I believe it's Unit 2. And so African Americans and Asian Americans may not respond as we expect them to antihypertensive treatments. And so if we need to keep that in mind. And then hypertension is very common in older adults. And this here is the current, per your textbook, guidelines for hypertension. And these guidelines have just been changed November 2017. And now what is elevated is 120 to 129. And hypertension starts at 130. And of course, those are systolic pressures. So just keep in mind that those are new but have not been published in your textbook yet. Antihypertensives, what do? Um, we are calcium channel blockers, we are beta blockers, both of those guys working together to help decrease the pressure, decrease the workload that the heart has to pump against. What do we want to watch for? Low blood pressure. So the problem with anything that helps lower blood pressure, it can go too low. So we want to watch those. We also want to watch for side effects like GI upset. With beta blockers, we watch for bronchospasms, and we also want to look for peripheral edema, which can be just a side effect or it could be an early symptom of heart failure as well. Antihypertensives, diuretics, we've talked about them for heart failure. We've talked about them just being used on their own for edema. Now we're talking about them for hypertension. So the common diuretics used to treat hypertension are your thiazides, your loops, and your potassium sparings. So, and remember the big thing to worry about with diuretics across the board is what is my potassium level? Okay, know that your loop diuretics are more potent than thiazides. And then we move forward to our beta blockers. So those are sympatholetics, which I have a hard time saying that word. Basically, what that means is they slow down the sympathetic nervous system. The sympathetic nervous system is our gas. It revs everything up. We're going to increase our heartbeat. We're going to increase our blood pressure. We're just going to be working harder. And if we block that, it's going to slow stuff down. Okay? So, like I said when I first talked about beta blockers, there's cardioselective and non-cardioselective. This is really important to know. So, if a beta blocker is non-cardioselective, it affects beta 1 and beta 2. Beta 1 is the heart, beta 2 is the lungs. So, we don't give these to patients that have COPD or asthma. Now, if we need to prescribe a beta blocker to those patients, we will use a cardioselective beta blocker. And the thing is, we still want to watch for any respiratory issues, no matter whether it's selective or not. And those most commonly are going to present with shortness of breath or wheezing problems. And we don't want to give if we don't want to give these if we notice that the patient has a marked decrease in their blood pressure or in their pulse. So if we are concerned about the pulse, we should take it apically, and we should always assess that before giving any beta blocker to a patient. We also want to educate these patients to not stop taking them abruptly because it can cause rebound hypertension. And know that, as I mentioned, due to genetic differences, African American patients may require a diuretic be added to their beta blocker in order to adequately control their hypertension. So this is just a little reminder, beta 1, beta 2. You want to have that. And then if you want to know which ones are which one, this slide tells you how to keep those straight. Then we've got sympatholetics continued. We've got our alpha androgenic blockers. And these lower blood pressure and cause some vasodilatation. They have some similar side effects, including orthostatic hypotension and nausea. They can also trigger some edema or weight gain, so we want to monitor for that. And this is our little slide. We can use alpha androgenic blockers for controlling blood pressure, but it's also for urinary issues and for BPH as well. Another commonly prescribed antihypertensive class is ACE inhibitors, and some common names are listed on this slide. So we know a few things about ACE inhibitors. We know that African Americans and some older adults don't respond to an ACE inhibitor by itself. But if we add a diuretic, we will get a better response. We also know it has a high potential to cause a dry, irritating, nagging cough. And if it does trigger that problem, we will try switching them to an ARB. These can also cause high potassium levels, so we want to monitor their potassium levels, and we want to assess for tachycardia. People that should not take an ACE inhibitor, those who are pregnant, those who are already taking aldactone, or if they have a history of a hypersensitivity reaction like angioedema, which is swelling of the lips, or it can even involve some peripheral edema as well. And we want to be careful if your patient uses a salt substitute, because salt substitute contains a high level of potassium, and it can really raise their potassium level to dangerous levels. This slide is just a little bit of a, okay, what do ACE inhibitors do? What are the side effects? And those orthostatic hypotension is a big one. And then I told you ARBs, they are very similar to ACE inhibitors, but they don't have that dry, nagging cough as likely to happen. So that's the big bonus with that. Next, we have calcium channel blockers. They promote vasodilatation. Ditalizam, verapamil, those are some commonly prescribed ones. Side effects, flushing, headache, dizziness. They can cause a little bit of ankle edema or even a slow heart rate. Or in severe cases, an AV block, which is more serious than just a slow heart rate. And this slide is in a nutshell. What do calcium channel blockers do? What are the side effects? So low heart rate, low blood pressure. So there's some BP and pulse assessment we want to do prior to giving a dose of a calcium channel blocker. And that brings us to the end of the commonly prescribed antihypertensives that you should be familiar with. And that leads us to anticoagulants, antiplatelets, and thrombolytics. So let's dive into these. So these are drugs that are used to maintain or restore circulation. Anticoagulants prevent formation of clots. Antiplatelets, they prevent platelet aggregation. Thrombolytics attack and dissolve blood clots that have already formed. Let's talk about these a little bit more. So what does it take for a clot to form? So basically what has to happen is an injury, decreased blood flow, or your blood is really sticky. Those are the things that causes clots to form. And what happens is our body wants to stop the bleeding and or fix the problem, or your blood just is clot happy. So what happens is your platelets initiate the process. They start clumping together. And then fibrin comes in to kind of help them fill in the gaps. And then red blood cells get trapped in that too. And that's what forms a clot. And that's why we have a three-pronged approach depending on what the problem is. So anticoagulants, the first one I want to talk about is heparin. Heparin is for rapid anticoagulation. So that's when a thrombus has occurred, So we're talking a deep vein thrombosis, pulmonary embolism, or even an evolving stroke. We can give heparin subcutaneously or IV. IV works really fast. If we use heparin, we have to monitor laboratory values, specifically the PTT. So whenever you hear heparin, think PTT. Then we've got Lovenox. Lovenox is something called a low molecular weight heparin. Basically, they went to the lab and played around with heparin and changed its molecular weight. This is commonly prescribed to prevent deep vein thrombosis after a surgery. And the nice thing about Lovenox is that we don't have to do the PTT lab values like we do with heparin. There are some contraindications for Lovenox, and that's for people that have stroke, peptic ulcer, or blood anomalies, and patients that are having eye, brain, or spinal surgery. So heparin, we're going to use it because a patient has a deep vein thrombosis, a pulmonary embolism, or an evolving stroke. Lovenox, we're going to use it to prevent those clots before or after, rather, a surgery, most commonly orthopedic or abdominal. Heparin, this slide just talks to you about how it's rapid acting, the different routes, the fact that we need to assess the PTT time, and how it actually works. And anytime a patient is on heparin, they need to be on bleeding precautions because we are inhibiting their ability to clot normally. So there are two types of anticoagulants we commonly see in the healthcare profession, heparin and warfarin. This slide is just a contrast, the differences between the two. So heparin is given through injections only. Warfarin or Coumadin is only given orally. Heparin starts working fast. Warfarin takes days. Heparin doesn't have a lot of drug interactions. Warfarin has a ton of drug interactions. Heparin, we are going to monitor lab value, the PTT. Warfarin, we're going to monitor the lab value, INR. Heparin antidote, protamine sulfate. Warfarin antidote, vitamin K. These are important things for you to know. Next, we've got direct thrombin inhibitors, and these are, they go directly to the thrombin and prevents conversion of the thrombogen to fibrin. And remember, that's part of the sheath, that the matrix that has to form for a clot to be fully formed. And these are a little bit newer drugs. The ones that can be given IV, the most common one I've seen is Angiomax. And then the other one I see prescribed frequently is the oral anticoagulant, Pradaxa, and that has a plus side where it doesn't require routine lab values. And another anticoagulant, this one that is oral, is warfarin or Coumadin, and chances are you've heard of this one. And we've actually had to look this up for one of our drug cards, and you know there's a lot of stuff that goes along with warfarin or Coumadin. So it interferes with how our body processes vitamin K and affects clotting factors. And so it's used to prevent thrombosis or embolisms. Particularly, it's very commonly used for atrial fibrillation because we want to prevent a stroke from forming. People who take Coumadin need some patient education. We want them to avoid eating large quantities of dark leafy green veggies because they contain a lot of vitamin K, and that's the antidote to Coumadin. We also want them to avoid taking any NSAID or aspirin product because it increases the risk of bleeding. We're going to monitor therapeutic range because if you remember, Coumadin is a narrow therapeutic index drug, and the lab values that we are going to monitor are PT and INRs. And there's some patient education. We want these patients to take their medication in the afternoon at the same time every day. They need to be on fall precautions. They need to have education of signs and symptoms of bleeding to report to their healthcare provider. And they need to notify their dentist and or surgeon that they are taking warfarin, because they may need to have their dose adjusted if they need a procedure done. So warfarin has some different indications, and that's what's listed here on this slide. And just a reminder, vitamin K is the antidote. And for acute bleeding, we can use blood products like fresh frozen plasma, but usually we try to control it with giving them injections of vitamin K. Let's see. So from there, we're going to touch base just quickly on some of the newer anticoagulants, Xarelto and Eliquis. The big thing about these is that they don't require coagulation studies. They don't require lab draws, which is a big plus to a lot of patients. The bad thing is they don't have reversals. And these are either administered once daily or twice daily. From there, let's talk platelets. Antiplatelets specifically, these prevent thromboses from forming by suppressing platelet aggregation or the clumping of platelets. Plavix, I can never say this one, clopidogrel, which Plavix is the trade name for it. Plavix is very commonly prescribed after a patient has a heart attack or a stroke, and this helps to prevent a second event. It can be prescribed by itself, but it is very commonly prescribed with a low dose aspirin because both of them prevent platelet aggregation, but in different ways. Aspirin, to talk a little bit more about it, it's an effective and inexpensive treatment option. So we can use it long term. We can use it at a low dose. We can use it, like I said, for people that have had a heart attack or a stroke, and it helps prevent a second event from happening. And that brings us to the thrombolytics. These ones, we call them the clot busters. They actually go in and break up clots. Activase, streptase, those are probably the most common ones that I've seen. This slide just shows you that they are clot busters. Sometimes they're abbreviated TPA. These can be used for people that are having a heart attack, people that have a pulmonary embolism, or even a stroke, to go in and break that clot up. So if they use it for a heart attack, there are some rules. It has to be a recent clot. It can't have been there for a long time. Usually it's within 3 to 4 hours. And we have to keep it within that window, because after that window, tissue starts to die and we can't bust the clot up without there being serious consequences. Okay, and that brings us to chapter 46. This is our last chapter. And this chapter we are going to talk about anti-hyperlipidemics and peripheral vasodilators. So let's first talk about lipids. We have some different categories of lipids. We've got high density, low density, very low densities. Remember that high cholesterol levels are linked to a high risk for coronary artery disease. Our HDL or good cholesterol, we want those levels to be high because that actually helps clean our blood. The low density or bad cholesterol, we want those to be low. And our very low density, mostly those are triglycerides, and we want those to be low as well. So there are different types of anti-lipidemics that we can use to get those cholesterol levels where we want them to be, especially if diet and exercise isn't making enough of a change. And I'm going to talk about some of these now. So the first one I want to talk about are your bile acid sequestrants. Questran is a very common one. So what these do is they bind with the bile acids in the intestines. So unfortunately, these cause side effects that are quite embarrassing, like flatulence, abdominal cramps, or constipation. And an easy nursing intervention is to encourage these patients to increase their fluid intake and slowly increase their fiber intake. And if they do those things, they should adjust to these medications. Next are the fibrates, gemfibrozil. This shouldn't be taken with anticoagulants. There's also niacin. These aren't used a whole lot because they have a lot of side effects and very few people can tolerate them. Cholesterol absorption inhibitor, Zetia. This one's a little bit more commonly prescribed. It acts on the small intestine to just stop how much cholesterol is absorbed, and it can be combined with a statin to get better control. And statins are the ones you're going to see prescribed most frequently. So they inhibit the synthesis of cholesterol. So that's why we take them in the evening for the best effect, because that's when our body wants to create cholesterol. Lipitor and Zocor are very commonly prescribed statin medications. And there's some patient education we have to provide to patients that are on statins, and that is they need to have annual eye exams to monitor for cataracts. They also need to report any muscle pain or cramping because that is a serious side effect. So they would want to notify their healthcare provider. We want them to avoid taking them with grapefruit or grapefruit juice, and we want to monitor liver lab values, specifically AST and ALT. So some important things to keep in mind with statin medications. Side effects, liver impairment. That's why we want to watch our liver enzymes, so ALT and AST. It also can cause rhabdomyolysis, and that's why we want them to report muscle pain or cramping, especially bilateral. Don't think electrolyte imbalance, think rhabdomyolysis if your patient's on a statin. And we want them to get annual eye exams because a side effect could be development of cataracts. So nursing interventions, we are going to monitor those liver enzymes. We're going to report any unexplained muscle tenderness, weakness, cramping, fever, or malaise. And we want these patients to take their medication on a regular basis in the evening to get the best benefits out of this med. Then we switch gear over to our vasodilators. Vasodilators do just what they say. The arteries and veins dilate. They get bigger. And so what that does is it improves the blood flow. So there's different classes of drugs that do this. Alpha androgenic antagonists, which we've talked about a little bit before. And there are select other antihypertensives. So they promote vasodilatation. Some specific examples is prazosin, That's probably one that I've seen. And Procardia, that's one that I've seen. So those are alpha androgenic blocker, calcium channel blocker. And then the big thing is the side effects. Because we're causing vasodilatation, we could get some lightheaded dizziness, orthostatic hypotension, tachycardia, palpitations, flushing, and GI distress. And that brings us to the end. So what I have for you on these last two slides is medications you need to know. You need to know the ins and outs of digoxin. You need to know nitroglycerin, both the slow and rapid. What are the beta blockers, including what do we need to know for all beta blockers? And then what do we need to know about cardioselective versus non-cardioselective? What do we need to know about ACE inhibitors? What do we need to know about specific diuretics, furosemide and hydrochlorothiazide? What do we need to know to safely give heparin, an anticoagulant, Lovenox, an anticoagulant, Coumadin, an anticoagulant, Plavix, an antiplatelet, aspirin, antiplatelet. What do I need to know to safely give statin medications? And then what about that chlorhistamine? What do I need to know to take care of my patients who's on that medication? So thank you so much for listening. I'm sorry that this was a really long presentation. It was just so much information. Please let me know if there's any questions or areas that I can clarify for you. Thank you so much.